Thank you very much. It's a pleasure to be here and cap off a very stimulating day. I'm do my best to keep you awake and engaged, and hope that we continue the discussions that we've had all day. It's my pleasure to shift the focus a little bit. We've spoken a lot so far today on looking at the experiences of persons with mental illness. We have spoken about issues from the healthcare system itself, and now what we're going to do is address the experiences of persons with mental illness who happen to be within the healthcare system. So what is it like for a physician or another healthcare worker to actually be experiencing mental illness and the stigma that's associated with that? I have to tell you, I got into this in a very interesting way. I am a child psychiatrist by training. I actually planned to spend my whole career doing child psychiatry. And I tease that I use my child psychiatry skills every single day with my physician colleagues in my office. But the reality is that, these things happen, right? There are life-changing moments that you don't expect and unintended consequences. Luckily, this was a positive one. So I was asked by a friend of mine who was the national president of the Federation of Medical Women the year, but maybe now about 20 years ago, to fill in at the last minute. They had a meeting here in Ottawa, and she called me Friday about 11 o'clock in the evening because the Saturday morning speaker at 8 o'clock got sick and had to cancel. So she says, what are you doing tomorrow morning, and can you fill in? And this is a group of female physicians in the audience, Federation of Medical Women. And she said, why don't you just talk about depression? The presentation you would give to senior, final year trainees in psychiatry, that might be very appropriate. And so off I went the next morning to do this. It's an interesting story because it speaks to the stigma. At the end of my presentation, I had 3 female colleagues come up to me separately and say, we really like how you approach depression. It sounded like you were telling my story, and you're not weird like I think psychiatrists are, right? And that really, this is from my colleagues. And that's 20 years ago, but that kind of stigma perpetuates, right? It continues on, and it really is a lot of what we're looking at. And not just about me as a physician or a psychiatrist, and I'll talk a little bit more about that, but also in terms of how people, the self-stigma. I had one of the 3 colleagues was a woman who I'd known for a long time. She was actually a colleague of mine from Ottawa, and she said to me, I hope you'll be able to take me on as a patient. And in psychiatry, we're taught in our training that we don't take on patients that we know well because there are other people that can do it, and it brings up all sorts of issues in the therapy. She said to me, I want you to take care of me. I want you to treat me because you've known me for a while, and you know that I'm not always like this. You knew me when I was at my best. Right? And that's the self-stigma, and that's actually partly what's motivated me and helped me recognize and probably had to reframe a lot of the boundary issues in terms of working with physicians. Right? But that's how I got started, and back then there was stigma. Right? And I'm sad to say that 21 years later, not much has changed. Let's talk about, at least we're talking about it though, and that's what we're looking at. So mental illness, healthcare professionals are not immune. Right? This is not something that happens to patients, right? We're patients too in medicine. And Erin, you spoke very eloquently this morning about, wanting doctors to look at you and say, I'm not my illness, I'm a person. I have patients in my office who are doctors who want to hear the same thing. They say the same thing to me. I'm a person, I'm not a doctor here, and when I'm ill and I go to the hospital or I need some treatment, I don't want you to treat me like a doctor. I just want to be a person who needs help that gets help. Right? So I want you to recognize what the similarities are, because that's definitely the case. And I will say that you can put any highly functioning person in an unhealthy environment, and they too will become unhealthy. Right? So this isn't just something that happens to the other, 1 in 5, or, what? None of us are immune to this. And we all need to watch this in ourselves as well as in our workplace environment. Here's another one, stigma. Healthcare professionals are not immune to this either, right? Set the stage a little bit, but this is what we see. It happens, and it happens to us. How does it happen? We've talked a lot about the culture and how culture perpetuates stigma. Guess what? The culture in medicine does the same, right? Here's our culture. We strive for perfection. We are encouraged to put our own needs at the very end of everything that we do. The culture sets very high expectations of ourselves and the people that we work with, promotes that hard work, that conscientiousness, that sense of responsibility, the need to do things perfectly, the obsessive compulsiveness that Michael spoke about earlier, encourages self-sacrifice and delay of personal gratification, and this then becomes a norm. This is what you're supposed to do when you're a healthcare professional, right? And some of the small groups that we're talking about in terms of stigma today are, I think Amy used the word marginalized. They are marginalized. So, we understand marginalized groups have stigma. What we don't understand and immediately recognize is this. Physicians aren't seen as marginalized. People that work within medicine in any capacity aren't often seen as marginalized. But guess what? We are disadvantaged, right? And it's not because of our socioeconomic status, and it's not our education level, and it's not our awareness and what we know and our literacy level, as was pointed out today. It's actually the expectation. So we're almost at the other end of the extreme, but both extremes are equally unhealthy, right? And they're not sustainable. This is the norm. So the ideal healthcare professional is supposed to come in early and leave late and be always available, pay attention to every possible detail you can, be always looking out for your patients. Be as responsible as you can. We're seen as being very tough. We're seen as the people that are in control, right? When other people have problems, they come to us. We're the ones that take care of other people. We help when we can. We provide the solutions. That's how we're seen. And we have to stand up to that ideal because this is the norm. This is what we're measured against, and this is reinforced every single day at work. Our teachers taught us this, although some of us, I think, had that personality, so we come by it honestly, but then it's reinforced by our teachers. It's reinforced every single day in our training, and it's reinforced by our patients, right? The people that come to us for help like it, that we're so available, we're so responsible, and that we want to do our best for everybody. So then we have stigma. Okay? And I've broken it down into 3 different things. Stigma is something that we do to ourselves in healthcare. Stigma is something we do to our colleagues. And stigma is something we do specifically to our psychiatric colleagues. So one of my colleagues said, I'm a fraud. How can I help other people if I need help myself? Right? I'm pretending to everybody else, all the patients come into my office and they're all doing great, and I cried every single minute of my drive into my office today, and then I dried up my tears, just fixed up, I sit in front of the patient and I pretend like everything's fine. And I can do this all day. What a fraud. Here's our misconceptions, right? This is one of the myths in medicine or healthcare, that we're never supposed to get ill. And we're never supposed to ask for help if we need it. And we see this, and again, this has been brought up today. It's not just about mental illness, it's about physical illness as well. I've had colleagues in my practice. I had an emergency doctor who told me that, she actually worked her whole shift. She's near the end of the 12 hours. It's like hour 11. She says, I have actually now admitted 3 women today that had a miscarriage, that were bleeding, that were just in such pain. And you know what? I finally went to one of my colleagues and said, I've been miscarrying this whole shift too, and can you now take over? This is what we do. Right? We don't know how to ask for help. I had a colleague who was diagnosed with cancer, and he said to me he didn't want to tell his colleagues in his department because, he wanted to wait actually till the pathology report came back, because then people would really believe him. Right? Like he's supposed to have documented proof, right? This is how hard we are on ourselves. And mental illness, right? That's even harder. I had a resident in internal medicine, came to see me as a patient, and he was slipping into depression, something he'd had before, and he knew the signs, and to his credit, he came for help. He said to me, it's been a tough month, right? I'm having trouble getting out of bed, and I'm having a lot of conflict at work, a lot of tension with my attending staff, the physician on the ward with me. And he said yesterday, he chewed me out in front of the patient, in front of all the nurses, in front of the family. He said, you're a horrible physician. You're totally irresponsible. You can't even get here in time every day. And I said to him, well, didn't he ask you why you were late? He said, no. I said, well, didn't you tell him why you were late? And he looked at me like I had horns on. He said, I would way rather he thought I was lazy than knew that I was depressed. Right? This is what happens. Some more examples of the stigma that we have within medicine that we do to each other. Doctors are known not to call for provincial helplines. We have over the years, in the last 20 years, as we've really watched and helped push the whole concept of physician health, and primarily physician mental health, although we're not very good at getting physical health either. You know, we've created networks, we've created helplines. Doctors don't call them. Like, that's just for like that's just if I'm an alcoholic, and or they worry that they're going to somehow call our regulatory college and our licenses are going to be impacted or are going to be pulled, right? So we don't go there. This is not that different from the fear of consequences that we see in other special groups we've spoken about today. Doctors don't attend workshops on stress. Right, so here I am very naively, I'm at the University of Ottawa, we've set up our wellness program, and I'm now starting some workshops. I'm thinking, this is great. People will finally see that I understand what's going on and I'm giving them something, that I'm reaching out to them. So I post it and lots of people are interested. We come up to the actual workshop, like a handful of people attend. And so, I meet up with the people that had told me what a great idea it was, over the ensuing weeks. I say, what happened? Like, how come you didn't come? They're like, are you serious? Like, I was going to walk to the medical school, into the area where the dean's office is, and walk through that door that you had plastered that sign on, the stress management workshop. Forget it. Like, there's no way I'm going to advertise to the dean that I'm stressed. Good point, right? These are the kinds of things that doctors don't want to be seen as having a problem or needing these kinds of supports. One of the reasons that my practice works really well is because I'm not at a hospital. Right? I am in an office building where there are dentists and accountants and lawyers, and in fact, all of them owe me big time because, when colleagues meet each other downstairs in the lobby, they'll say, oh, I'm just here to see my lawyer, or I'm just here to see my accountant. So they've actually started to use the services of everybody else in my building so they can actually honestly say why they're there. And in fact, when I first was taught psychiatry, we were taught, the waiting room setup of you come in one door and you go out the other. And that was partly to protect confidentiality and anonymity. And I tried to do that. And then I realized, with physician patients, I'm actually reinforcing stigma. So I spoke to my patients about it, and I really just had people wait in the waiting room. And people would come in and leave through the waiting room. And I asked everybody, I spoke about confidentiality, but and everyone, and certainly in 20 years, that confidentiality has never been breached. But people have told me the value, and again, the value of contact. Right? People have told me how important it was for them to run into somebody else in my office and think, that is the last person I would have thought to have seen here, right? And they say, we go through the hospital, we do the stuff we always do, but we just, when our eyes connect, we just look at each other a little bit differently. It's a slightly different experience because we know we share something. We don't even have to talk about it all day. I have patients in my practice who tell me that, the psychotherapy part, they can accept that. It's okay to come talk to me because this is educational, right? And we're good, we've done a lot of educational stuff, so we can come see a psychiatrist. But taking medications, that's just for psych patients, right? And that's where they draw the line somehow. It's all totally arbitrary. It's all very interesting when I hear this kind of stuff. It's been very educational for me. But what we're doing is just seeing how that stigma continues. We're caregivers. This is how we see ourselves. We're not care receivers. And heaven forbid somebody tells us we need help. Heaven forbid something happens where we need it ourselves and we have to reach out and ask for it. Here's another colleague heard this statement. I hear you're off for a few weeks. Must be nice. Right, so this is a colleague who's aware she's slipping into depression, is trying very hard to do the responsible thing, and so is and I've suggested to her, maybe she needs to be off work for a while. And like a lot of highly functioning professionals, your ability to function in the workplace is really one of the last to be impacted. right? We can get through our workday, do the things we have to do, almost an automatic pilot, and then it's at the end where we don't have any time or energy for the extra stuff. So she said, you know what, I agree with you, I'm just struggling with this more and more, but you know what, give me 2 weeks, right? So for 2 weeks, she worked day and night, finished everything she had to do, wrapped up all the stuff, tried to be as organized as she could so she could be off for a while. She's on her way out, right, having struggled almost every second of the past maybe 6 months. She's got this box she's taking out to her car when she hears this comment, right? Must be nice. Yeah. So we do this to our colleagues. We do this to each other, right? Doctors, again, are seen as being somehow weaker or less if they have a diagnosis of illness. Maybe they're not trying hard enough, right? Maybe it's their fault. Again, we've heard these kinds of comments from all the other small groups. That sense of shame and judgment and reprisal. And again, Amy, in her science and her research, was able to show how that sense of shame led to delay of access to treatment. Guess what? Same as what happens to doctors and other healthcare professionals within medicine. We feel like there's this lack of support and understanding, and certainly mental illness is much bigger than any other physical illness we could possibly have. And again, we've heard the similar stories, but this too happens in medicine, where, and this happened in Ottawa, right? It's a true story, and we've alluded to it. Mike was talking about, the senators not coming on to the child psychiatry ward. So in Ottawa, there's a department. 2 members of that department get ill. One has an acute heart attack and ends up in the Heart Institute of their hospital, and the other has an acute depression and ends up in the psychiatry department and the ward. The colleague with the heart attack, right, was the one telling me the story, because he felt really badly about this. He said every day he had colleagues come to visit him. Every day he got cards. The department sent this big bouquet of flowers. They were very, very happy to, come by, see how he was, asked about his treatment, asked how he was feeling. He said his colleague, who was hospitalized the exact same period, same hospital, but on the psychiatry ward, didn't get 1 visit, 1 card, no flowers. He said to me, it's a very wonderful francophone, and so in his francophone accent, I can hear it in my head, he said, I had the noble disease, right? That's what he had. And let me tell you about this noble disease thing, because since then, I've done it, and with all due respect to my colleagues at the Heart Institute, but I had a patient once say to me, this was a medical student actually, and her parents were so happy with the care that she'd received and how well she'd done, and the fact that she was able to, with some help, continue and graduate as a physician. So she asked me at her graduation to give her graduating diploma. I was very, very privileged to do this, and I got to meet her parents, and they said to me, we are so happy with what you have done for our daughter. In fact, we are so happy that we have made a donation to the Heart Institute in your name. Now I have no idea where that connection comes from, except that, they wanted to give, right? But heaven forbid they give to mental health, right? And then this comment, you're gonna switch to what? Why would you wanna waste your medical training like that, right? Mike talked about sort of the cultural aspects of, and he talked about the Asian culture. You know what? The Indian culture is no different. Right? I actually went into psychiatry for a couple of years just so I could delay telling my mother that I wanted to actually do psychiatry. Here are the misconceptions about psychiatrists. We're not real doctors. What we do is not real medicine. Right? There's nothing quantifiable or scientific. Actually, people aren't even really sure what it is we do all day long. It may be some vague stuff, all of which just leads to the mistrust that we see in the culture and in the community. We see things like, comments perpetuated like, psychiatrists are all weird, we're all crazy, we're all incompetent. As I mentioned earlier, my very first psychiatry or physician patient, that was her comment, right? That you're not weird like I think psychiatrists are. And our colleagues do devalue and dismiss our needs, We spoke about, in the emergency room, the psych room is often the one at the very end of the corner where, if we can just put you and your patients away and we don't really have to watch you or interact with you very much. People don't come to see consults when we've asked for them. Lots of waits for patients that are known to be psychiatry patients, right? We've discussed a lot of this. I want to just refer to the work of the Canadian Psychiatric Association Stigma Discrimination Working Group. In 2008, we surveyed our members and just asked them what sorts of experiences they had about this, and really reinforced a lot of what I'm telling you. 75% had an experience of stigma and discrimination towards psychiatry as a profession and their choice of that. 53% had a personal experience of stigma and discrimination as a psychiatrist, and 70% were telling all these great personal stories that reinforced all those misconceptions that I've told you about. So what happens as a result of this? Guess what? It's no different than anything we've heard today in any of the other groups. All of the same things happen. In medicine, what we do is use that sense of self-stigma to reinforce a lot of our defenses. And defenses are just these little mind games that people play to not have to deal with some of the issues that they have to. So we deny, right? We don't have a problem, everything's fine. Well, sometimes we can't deny. We minimize, okay, maybe I am not coping at my best, but it's not so bad as Michael, and as soon as Michael goes for help, maybe I'll start thinking about it, right? But we start to kind of have our little games that we play, so still the end result is we don't go. Or rationalizing, it is true. I'm really not coping well, but it's just because I haven't had a holiday in a year. As soon as I get away, right, I'm going to be fine. I know I just need a break. I just need to kind of, do a little bit of R&R and chill on the beach, and I'm going to be okay. And we can rationalize every single day of our lives, again, and not have to acknowledge any of these issues that happen. In medicine, unfortunately, we have access to medications. And so, and I say that unfortunately because, if we didn't, none of this would be a problem. But because we do, and of course we can't reach out for help, what happens? We treat ourselves. In fact, we diagnose ourselves, we treat ourselves, we start ourselves on medication. I actually did a survey of my patients about 8 years ago. I looked at the last 100 doctors that had been referred to me. 82 of them had already started themselves on an antidepressant medication without the knowledge or the advice or any intervention from a family doctor before they'd even walked into my office. And I think that's just the tip of the iceberg, right? Those are the ones that told me. Those are the ones that walked into my office. I don't really know how many are out there. Some of the medications we have actually are quite good. And certainly for a short period of time, they'll do the trick. They obviously are not on their own the only treatment or the only help that somebody needs. But I suspect a lot of people use it as a crutch within our profession. At the end of the day, it delays seeking help, right? Again, we've talked about this. You see the themes. I really wanted to lay for you that physicians are people. We're not that different than any of the other persons with mental illness we've spoken about today. And also, it can lead to more serious illness, right? By the time a doctor reaches out for help, they've already waited the 9 to 12 months, right, that it takes to actually access, right? What we see are much more, the patients I see in my office are much more ill than a lot of patients I've ever seen in my training because they've let it go for a lot longer. So where do we go with this? I think it's really important to stop and reflect on our own personal stigmatizing beliefs and attitudes, and you'll see that what we're talking about is really what we've again talked about today, the PEC, right? The protest and advocacy, the education, and then the contact as well. I just want to make a little reference to the implicit association test. This is a test that we found online, was brought to my attention by Leila Dabby. You'll hear from her tomorrow, and she hopefully will tell you more about it as part of a project she's involved in. But, really, it's an online little survey that talks about what your own implicit associations, really what your attitudes and stigmatizing thoughts are. And I'm thinking, I don't have any stigma. Right, look at me. I am visible minority, female, psychiatrist. I don't have the right to have any stigma for anybody else. And so I take this test. I am shocked. I was actually embarrassed to tell. I went to tell Layla. She's part of our stigma discrimination working group at the Canadian Psychiatric Association. And I'm like head down, walking into this group going, I can't believe how high I scored on this test, right? Totally unconscious. Now, with all due respect, luckily it didn't translate into behavior, but still, right, this is what we walk around with. And I'm a perfect example of what you say about, it's not about the literacy, it's not about the education, right? There are some beliefs we have, and there's even these stigma within stigmas, right? That we've got our own little things. Very interesting to do, and if you ever get a chance, really recommend you to do that, because it highlights things that we don't really want to know about ourselves, I think. I think that, in medicine, and particularly in terms of psychiatry, I think there's a lot of education we can do at an earlier level, like we've said about so many things. For us, it translates in our medical training and our medical education. How can we talk more about psychiatry? How can we have more contact with psychiatrists and show people we are actually quite normal? How can we foster some collegiality so that our colleagues in other specialties, including surgical specialties, we sort of have this sense of demystification about what it is we actually do and who it is we actually are. I think that, again, education, one of the things we set up here in Ottawa is the Neighbourhood Watch program. And this is just like in your own neighborhood where you have a program where people kind of watch out for each other, right? And you've got the little sign in your window that says, if you have any trouble, this is a house that's safe. You can stop here. And we took that and translated that into every department at the university, at the university here, the medical school has a University Watch program where basically, you now know and there's a little bit of education to be done. But what you're doing is creating this environment where people can, if they're starting to struggle, know that they can talk to colleagues. And we've taught people, what do you look out for? How can you reach out? And the worst thing somebody can say is, no, actually I'm fine. I'm just, I didn't get my hair done today because I was running late, not because I'm starting to become depressed again. And that's okay, right? But it fosters a sense of, I care about you. And I know that when you ask me a question or reach out, it's because you care about me. Right? And how can we create those sorts of attitudes? And a lot about sharing stories, a little bit of what I, as well as everybody else in the room, has been doing today. But really, that's how we're going to do this, right? That to see that we're not alone, that there are good stories, there is recovery, there are positive outcomes, there's a lot of hope. And I really want to leave you with a message that it really isn't a we versus they sort of situation. That the doctors and the healthcare professionals are just as committed to reducing stigma as every single person in this room. Thank you.